Good morning, Doc. So here's the case we were talking about earlier. In essence, the patient has lower anterior crowding, somewhat class 2, maybe mildly class 2. She had her premolars extracted, and she's a intracapsular and extracapsular TMD patient. So here's what I would say. The patient doesn't want to do any class 2 corrections or any sagittal corrections. She has very wide teeth on the upper anterior, which means we can't unravel her potential Bolton discrepancy through expansion of the upper arch because her teeth already look too wide. So really, our only option here is to do IPR on the lower. We had discussed emphasizing to the patient that doing IPR in a patient with TMD and a potential airway and already deficient arch form based on the fact she's missing her premolars is not advisable. She only just wants to unravel these here. So here's what I'd recommend. Before I go through that, there is a concept that I want to share, which is the following. When we have anterior crowding, this is true on the upper or the lower, the interproximal bone and the interproximal tissue is not the same as teeth that are not crowded or not overlapped. So if you think about it in your mind's eye, where is the bone on this tooth? It's farther down in relation to the future contact point. Let's draw to come over here. Let's draw a parallel situation. Contact point, level of bone. Over here, because of the crowding, the bone is actually farther down on the facial surface of number 24 here. Why is that important? When you unravel crowded teeth, the patients, especially older patients, have to know black triangles are likely to ensue. So having that conversation ahead of time with any crowded case is super important. Fortunately, if we do IPR, we can create space and then squeeze the teeth together, in essence bringing the roots closer together, which will, in essence, hopefully, squish the tissue in the bone interproximally to a more incisal level. That's a topic for a good perio-ortho continuum. Just know that when we do IPR, we can close black triangles to some degree based on a similar concept. Yes, we can use restorative methods too, but closing every black triangle with restorative methods is a great after-the-fact method. So what can we do ahead of time? Well, we know we want to do IPR here. Okay, so what I would say is let's plan on doing the lion's share of IPR here between 24 and 25 and not so much over here. But the teeth are crowded to begin with. So there's something called timing of IPR. The IPR doesn't necessarily need to be done all at tray 1, 2, or 3, or whatever Invisalign says. I think here they had recommended, so when these turn yellow is when IPR is programmed. What I would say is tell Invisalign to turn off the IPR on tray 1 between 24 and 25. I actually think it'd be best if we actually don't program any IPR here until we're done and we see how much of a black triangle exists. And then we program the IPR between these two teeth. And that's for a couple of reasons. One, we want to see how much of a black triangle she has. She's going to have some negative overjet, most likely based on the Bolton discrepancy and the involvement of her TMD. Her mandible might kind of drift forward as we provide more treatment. As a result, we don't necessarily know exactly how much IPR she needs for the final result. So what we're doing is we're underestimating how much IPR is needed. And then when we do our refinement trays after the end of these 12 trays, and then we'll program in the IPR here based upon those variety of factors that we just talked about. So as you can see here, that's a very difficult place to do IPR. You can take a 856-012 burr, just like a diamond crown prep burr, and reduce that, and then reduce that. You don't have a whole lot of control because of the space constriction here. You're not going to get 100% of the IPR down in this area here. So I don't like doing IPR on teeth that are crowded, especially this crowded. So I would remove the IPR in between 24 and 25. I would reduce the IPR between the other teeth here down to 0.2. Again, we're going to put more IPR here based upon the black triangle that's likely to happen based upon the crowding that we see, thinking with the end in mind. So 0.2, 0.2, 0.2, 0.2, 0. Have the IPR in these happen on tray 1. Have the patient go through the 12 trays. Whatever we end up with the unraveling in this section here, we will do the remaining IPR that's needed to, 1, close the space here, but also 2, get rid of the negative overjet. That will dial in the proper amount of arch length and decrease the chance of any sort of aesthetic compromise that comes with black triangles. The last thing I'll say is when we program IPR, especially lower teeth, the lower laterals are often wider than the lower centrals. When we do IPR, Invisalign is just saying create space. They're not telling us that we need to take 0.15 millimeters of enamel here and 0.15 here. We can control through the use of one-sided diamond discs. So you have to intentionally order those IPR discs so that in a situation like this, you're reducing the wider tooth. You don't want to reduce 50%, 50%. Here, I would do 100%. See how much enamel you have here? Making this tooth look more square rather than triangular is actually a good thing aesthetically. So know when you see IPR that sometimes you want to take from both sides and sometimes you want to take from one side. To take from one side, you need one-sided IPR tools, and there's many tools out there. Keep that in mind as you do IPR. Don't be indiscriminate in the removal of enamel. And here I would focus it there. So that's pretty much it. I think this will be a relatively quick case. I wouldn't try to do this in just 12 trays. I like the idea of refinements. Educate the patient on a potential posterior open bite based on the fact that she's relatively trapped already. I think her TMD actually exists because of the fact that she has this, I call this a distalizing interference. Her entire mandible might be a little farther back, which would include her condyle inside the disc space because of this little piston right here, or stiletto heel. As a result, she's more likely to have a posterior open bite created through just resolution of this lower anterior crowding because of how trapped she already is. So as you create good arch form down here, it's very possible that the teeth are going to interfere during closure, which might cause what appears to be a posterior open bite. That's a relative posterior open bite. In other words, the teeth are fine out back. It's not that they're not touching, it's the fact that the front teeth are touching too soon. We will resolve that, educate the patient on the fact that she might have a posterior open bite until we get the IPR between 24 and 25. So I hope this helps. Let me know if you have any more questions. Take care.